I'm very happy to be providing this update on COVID-19 therapeutics for our May program on the COVID Clinical Forum. This is a particularly interesting time to be speaking about COVID therapeutics because the day that I'm recording this, which is May 11th, is the day that the United States is ending the declaration of a public health emergency. And of course, earlier we heard the World Health Organization declare an end to the COVID-19 emergency worldwide. These are my disclosures. Today, I'm going to cover 3 topics, provide an additional update on nirmatrelvir ritonavir based on some data from a large healthcare system, speak about the C5a inhibitor vilobelimab, and talk about an interesting study that looked at the combination of fluvoxamine with inhaled budesonide. Well, let's talk first about the additional data that have come from a large U.S. healthcare system on nirmatrelvir ritonavir. This was a retrospective cohort study conducted by Kaiser Permanente in Southern California. In the United States, Kaiser Permanente is one of the very large healthcare providers. They have a health plan that has really hundreds of thousands of people, if not millions of people, who receive their care through their system, and they're particularly used in the western part of the United States. The study tracked data from outpatients who were aged 12 years or older who had a positive SARS-CoV-2 PCR test. And the primary endpoint was all-cause hospitalization or death within 30 days of the positive PCR. The goal here was to determine what were the outcomes in those who did or did not receive Paxlovid or nirmatrelvir ritonavir despite having a positive PCR test. We can see that there was quite a distribution in the timing of various parameters related to COVID-19. The top panel here, panel A, shows the timing from symptom onset to PCR testing. And you can see that the majority of people tested within 4 days or so of having symptoms, with the most frequent testing occurring within a day or two of symptom onset here. But there were a significant proportion, maybe 13 or 14%, who tested positive without any symptoms at all. Now, if we look at how rapidly a drug was initiated after having a positive PCR test, we can see that about 35% started drug the same day that they received their PCR test result. And then another 50% or so started Paxlovid or nirmatrelvir ritonavir within 1 or 2 days of receiving their positive result. And if we look at what was the time from symptom onset to starting drug, which is in essence a fusion of panels A and panel B, we can see that the largest proportion, about 17% or so, had symptom onset 3 days before they started drug, but the majority of patients were within 5 days if you aggregate all of these folks. Now let's look at how these factors play out over time in terms of the uptake of nirmatrelvir ritonavir, what proportion of cases were treated, and what types of individuals were treated in terms of various risk factors, because some very interesting data emerge. So first of all, you can see just from panel A, this is essentially looking at the epidemiology of COVID-19 in Southern California during this period in 2022. And what you see is these are in tens of thousands of cases here at the nadir in the spring of 2022. So here we had 80,000 cases at the peak of the Omicron BA1, BA2 wave, and then things quiet down and then they pick up again. Nirmatrelvir ritonavir dispensing picked up dramatically during May and June of that year, and then tailed off as cases fell off. But the proportion of cases treated continued to increase, but it was always a minority, never reaching much above 12 or 13%. Not surprisingly, it was older people who were much more likely to be treated, and people who had a variety of comorbidities using the Charlson Comorbidity Index were also more likely to be treated than those who had no risk factors. And that, of course, corresponds to the parameters of the emergency use authorization. But a very interesting phenomenon, and something we'll dig into in another slide, is that people who had received at least 4 vaccine doses, that was the maximum number of vaccine doses you could have received, that is the 2 initial vaccinations plus 2 boosters back in this time period. People who had received all 4 vaccines were far more likely to have gotten nirmatrelvir ritonavir if they had breakthrough infection than those who had never been vaccinated. And this suggests that one of the potential biases in these data are that people who already exhibited health-seeking behavior because they were more likely to have been vaccinated were also more likely to either request or accept nirmatrelvir ritonavir if they did indeed develop COVID-19. And here we see in this table this striking relationship in terms of the proportions of people who did receive nirmatrelvir ritonavir versus those who didn't. And you can see that this increases the 60% of the people who had 3 or more doses did receive nirmatrelvir ritonavir compared to those who had received 2 or 0 doses, whereas more people, 13% of those who were never vaccinated, did not receive nirmatrelvir ritonavir. Well, how effective was nirmatrelvir ritonavir in this population? Well, if we look at all-cause hospitalization or death, you can see that for those who started drug within 5 days of symptoms, and remember from the earlier slide, that was the vast majority of people, about the drug was about 80% effective in preventing hospitalization. And if you took it at any time, it was about 54% protective or effective. If we look at ICU admissions, the drug is highly effective, about 85 to 90% effective, although it failed to reach statistical significance here for the group within 5 days of symptoms because the numbers were so small. And then looking at effectiveness as a function of vaccine receipt, essentially for all people, no matter how many vaccinations they had received, the drug was highly effective, achieving 80 to 90% effectiveness if you took the drug within 5 days of symptom onset. Well, let's talk now about vilobelimab. Vilobelimab is a C5a inhibitor. It's a monoclonal antibody. And just to remind you about the role of C5a, C5a is part of the complement activation pathway. Remember that complement can be activated by several different pathways, and the C5 convertase enzyme converts C5 to C5b, which forms the membrane attack complex that attacks bacteria and other invading pathogens, and C5a, which then serves as a chemotactic factor. C5a has an important role in activating polymorphonuclear leukocytes as well as macrophages, and therefore can contribute to inflammation in an important way. So the Panama study sought to interrupt the C5a-R1 axis, the receptor being C5aR1, in order to limit damage from inflammation in the lung and at endothelial surfaces. This was a double-blind, placebo-controlled, randomized clinical trial in patients who were receiving mechanical ventilation for COVID-19. So remember, we've spent a lot of time talking about treatment in symptomatic outpatients, in people with moderate to severe infection in the hospital setting, but we've really had very little to offer people who are the sickest, those who are in the intensive care unit on a ventilator. This study was conducted worldwide in Europe, in South America, and in South Africa. The primary endpoint was all-cause mortality at 28 days, and this was done in the period from October 2020 to October 2021. So during the time that vaccination was beginning to be rolled out, but where most people were still not vaccinated, although remdesivir and dexamethasone were widely available as therapeutics at that time. This slide shows the primary result. Here on the left, we see the outcome at day 28. And on the right at day 60. And what we see is that there was a reduction in mortality, although not a statistically significant reduction, achieving about a 25% reduction in the risk of mortality for those who received the antibody at days 28 and days 60 compared to placebo. But there was a statistically significant reduction in time to first renal replacement therapy, which is really quite interesting if you think about the mechanism of injury that we're trying to prevent by blocking C5a and the role that endothelial inflammation may play in renal injury, as well as renal failure and the need for dialysis being a marker of severity of illness overall. In addition, it was very interesting that there were significant differences in outcome based on geography, so that there was a statistically significant effect on survival in Northern European countries that was not seen in South American countries or in South Africa, suggesting that other factors and access to other therapies played a big role in modifying the outcome and therefore in altering the overall result of the study. We look by different subgroups. You can see that the sicker the patients were, the bigger the effect of vilobelimab on outcome. This was also true of whether, if we looked at the severity of their hypoxia and pulmonary dysfunction, and also looking at the severity of their renal function at study entry. Well, let's finish by talking about fluvoxamine with inhaled budesonide for early onset COVID-19. Previously, we've talked about results of the ACTIV-6 study that looked at fluvoxamine by itself and really found no significant benefit at all. And we've seen modest effects of budesonide. This was in a study that was published 2 years ago now, and showed that inhaled budesonide using Bayesian statistics here had a very high probability of being superior to placebo in outpatients who were symptomatic and had a positive SARS-CoV-2 test. This study was a randomized placebo-controlled adaptive platform trial, and participants were symptomatic adults with positive SARS-CoV-2 PCR and a risk for disease progression. This was a study conducted entirely in Brazil, and the participants were randomized to receive either the combination of oral fluvoxamine plus inhaled budesonide or matching placebo, so no drug at all. And the primary outcome was COVID-19 related emergency department visits that lasted at least 6 hours, or hospitalization, or a suspected complication due to progression of COVID-19 within 28 days of randomization. This trial, which was known as the Together study, was analyzed by primary and secondary outcomes, again, using Bayesian statistics. And the top line here in this table shows the likelihood of having a primary outcome, the emergency department visit lasting 6 hours or longer or leading to hospitalization. And the risk was reduced by about half. The probability of the intervention being superior to placebo met the threshold. The probability was 98.7%. Remember here, when we're dealing with Bayesian statistics, the higher the p-value, the more likely it is that this is a true result. And there was about a 60% chance that there was a modest 10% reduction in hospitalization, not reaching the threshold of significance. None of the secondary outcomes achieved statistical significance. Looking at subgroups, we can see that in the overall intention to treat analysis population, as I just showed, there was about a 50% reduction. And now here we're using standard statistics, but with a credible interval rather than a confidence interval. And then if we look at time from symptom onset, the longer from symptom onset, the greater the effect, which is a little bit counterintuitive. And people who were non-obese also had a bigger benefit compared to those who were obese. Likely those who were vaccinated had a bigger effect than those who were unvaccinated. So in conclusion, nirmatrelvir ritonavir showed significant benefit in symptomatic outpatients in a large healthcare system. Uptake was highly skewed, though, to those who already were demonstrating health-seeking behavior around COVID-19. C5a blockade with velodelimab in patients receiving mechanical ventilation improved outcomes that was highly dependent on where the patients lived, with a bigger effect seen in Northern Europe than the rest of the world, and it delayed time to renal replacement therapy. The combination of oral fluvoxamine and inhaled budesonide may provide some benefit, but paradoxically, that benefit seemed to occur in those who might have needed it least, compared to those who were at higher risk of progression, such as those with obesity and those who were unvaccinated. I look forward to the discussion.